Hello, and welcome to today's virtual program hosted by the Healthcare Council of Chicago. My name is Megan Phillip, and I am the Executive Director of HC3. 2022 marks the 5-year anniversary of the inception of HC3. We have evolved into a mission-driven platform convening healthcare leaders and stakeholders across Chicago to address issues and barriers that our industry face. As we gather today in the beginning of a new year, it has become a tradition of HC3 to reflect on the year prior and offer some predictions for what we can expect or are already starting to see happening in the year ahead. So before I make some introductions to our wonderful guests, I have a few housekeeping items. This morning's discussion will be recorded and shared on our website, www.hc3.health. And as we hear from today's experts, if you have any questions, please use the chat function and we'll do our best to address those later in the program. Today's forum was generously supported by one of our HC3 members, the Illinois Health and Hospital Association. Here to share some remarks is a member of IHA's leadership team, Jordan Powell, Senior Vice President of Health and Policy.
Thank you for the introduction, Megan. And I'm so pleased to be here today representing Illinois' more than 200 hospitals and nearly 40 health systems that serve their patients and communities throughout the state. I want to thank the Healthcare Council of Chicago for hosting today's 2022 State of Chicago Healthcare Forum. And I'm especially honored to be here today alongside healthcare champions leader Mattie and David Munar, who I've had the pleasure of working with for many years. And I think it's fair to say that we all hope to start 2022 on a better note. It's been a long road for everyone, but especially for our frontline providers who are fatigued and weary of this ever-present virus and its impact on their friends, family, and neighbors. You know, they've witnessed firsthand the heartbreak it has caused, but they remain committed and compassionate, doing all they can to provide excellent care to everyone who walks through their doors. They've been extremely resilient, and I think that's the word for 2022. You know, the last few years have proven to be extremely difficult, but we need to remain resilient in improving patient care and access and advancing health equity and addressing the significant challenges such as staffing that are a result of the COVID-19 pandemic and that will continue to be here long after the pandemic ends. And I know we'll be likely discussing many of those challenges today, and I really look forward to this morning's discussion. Thank you.
Thank you so much, Jordan. And thank you again to IHA for your continued contributions and your support as a member of HC3. Without further ado, it is my pleasure to welcome today's moderator, David Smith, co-founder of HC3 and founder and CEO of Third Horizon Strategies, to do some introductory insights for our conversation today.
Thanks, Megan. It is my pleasure to be welcomed, and certainly my pleasure to be with all of you this morning. Thanks for taking the time out of what I know are busy schedules to spend with us talking a bit about where we've been over the last several months in particular, and ultimately where we're going or where we need to go in the weeks and months ahead. One of the things I want to be careful to not do in the course of this discussion is spend an overabundance of time looking backwards. I think we've all cultivated a point of view about our cultural, social, governmental, corporate responses and behaviors over the last couple of years, and certainly the confluence of those things will continue to be litigated in the months and years ahead as we really try to learn and grow from this. What I do want to do is I want to kind of recognize that COVID-19 has served, is serving, and will continue to serve as a prospective inflection point for our system. And what we choose to do with that, I think, is a matter of our own collective decision-making and actions as we seek to understand the last couple of years and look to make a better system that is more inclusive, that is more equitable, that is more accessible, and that is more affordable as we move forward. You know, as I was thinking a little bit about what I wanted to say just in my initial remarks. I'm a consultant, so consultants tend to do everything in threes. So I just have three things I'm thinking a little bit about. We may touch on these in whole or in part as we go through the panel, but I thought I'd share them anyway. The first is that, I think where we are now is, for the advent of our modern health and health services delivery system is really only about 60 years old. And it has not been tested or put under a significant level of duress in quite the same way it has been tested over the last couple of years. And I think there's something important about that observation, in that we have moved from a theoretical understanding of why our systems economics are disjointed and misaligned to a really strong scaled application and kind of this meta use case that really shows us everything. What happens when you do have a sustained fee for service payment system? What happens in other states when things like behavioral health are carved out? What is the real impact of social determinants of health? How do we think about managing populations to improve outcomes? These are all things we've talked about in the abstract. We've studied specifically in the local communities as we've tried to bend the cost curve, so to speak, in different ways. But we have never seen the kind of scaled application of this type of economic duress ubiquitously across the country at once. And what it does is, and I hate the term, it shines a light, because these are all things we kind of had intimated or postulated in the past. It does more than shine a light. It demonstrates very clearly what does and does not work about the way we've organized resources across the country, and certainly in the state and in the city of Chicago. The second thing, and I want to just kind of call out give a shout out to something Jordan said a moment ago, which is that we are nothing without our workforce. And I know we've all said those words or expressed those sentiments in different ways at different times. But now we're starting to feel it and experience it in a way that I think really important. Like every other part of our healthcare delivery system, our workforce is governed by economics and the supply and demand of labor. And it turns out that paying specialists, $250,000, $350,000, $500,000 a year, and paying mid-level practitioners or therapists a fraction of that does not make for a system that has a sufficient number of caregivers who are not only motivated to do the things that are most important for patients and communities, but who cannot abide by or sustain the tremendous pressure, stress, at times beratement that they might experience by virtue of that chosen profession. And this is a serious problem. And it's not one that's just going to fix itself. It's not one that's going to just go away because we will it so. We are going to have to invest heavily into not just rebuilding our workforce, but really reimagining the economic structure of it, scope of practice, compensation, extending scarce resources or scarce infrastructure through digital means. Everything is going to have to be on the table. And I do believe that is going to be an existential part of our path forward, and something we have to do a far better job managing for in the future, with or without any other succeeding crises. The third thing I've thought a lot about, especially given all the healthcare transformation work that's going on through HFS and the state, is that talk is cheap. We talk a good game about social determinants, and we talk a good game about health equity and diversity, equity, and inclusion, and all these things that kind of become the topic du jour at a particular moment. We are at a critical moment where talking is no longer going to check the box. We have to do better. We have to do better in outlining what we expect of this system. We have to do better at conceiving of policies that can regulate and direct the system to give us the results that we want. We have to do better at holding the system accountable. And I say that from the perspective of a person in this industry, a person who has been a patient, and a person who pays taxes into the state, and a person who does a lot of work in different parts of the city that do not have the fortune or the advantage that many other parts of the city have. There is a tremendous opportunity right now to thoughtfully reconcile the way we move money in this state and into communities, resource those critical men and women on the ground who tend to our neighbors, and do that in a way that doesn't just bend the cost curve or improve chronic disease outcomes. It's about improving lives and giving everybody in our city the same opportunity to have a quality of life and to be the best version of themselves. And that's a responsibility I feel more and more as I get older. And I know that's a responsibility and an obligation that many of you feel by virtue of the fact that you are in this profession and you've dialed in this morning. I am, and I say this so cautiously because I've tended to be so wrong about so many things over the last 2 years. I am cautiously anticipating a better 2022. I have to believe, like many of you, that one way or another, we are going to start to develop our post-COVID societal and cultural norms, whether there are subsequent variants of the disease or not. And so in anticipating a better 2022, I think we have to acknowledge this system is not going to just fix itself. And any one of us that have settled into thinking transformation and change in the system as a spectator sport, we're in the wrong business because it's not. There are certain critical stakeholders and leaders that are going to have to abdicate and extricate themselves from the way we have done things in the past, the way we have concentrated power in the past, and ultimately shift the system in the direction of a common vision, one that really does focus on optimizing human potential of those men, women, and families that live and work in our communities. So with that, we're really excited to have a set of 3 people that are all individually and certainly collectively smarter than I am. You met the first one already in Jordan Powell, Senior Vice President of the Illinois Health and Hospital Association. Jordan has been a wonderful friend and ally to the Healthcare Council over the years, and I want to echo Megan's gratitude for their support of the event this morning. Second person I'd like to introduce is Senate Leader Mattie Hunter from the 3rd Senate District of Illinois. If you've done anything in the safety net or in public health in the city of Chicago or the state of Illinois, you have seen Leader Hunter's name or you have crossed paths with her. I have probably listened to Leader Hunter far more than she's ever listened to me. And every time I do, I walk away a little bit better, having been the beneficiary of her insights and experience. And lastly, we have David Munar, who's the president and CEO of Howard Brown Health. Howard Brown Health is a federally qualified health center. They do tremendous work. We've known David and his colleagues for years, and David always just brings wonderful and rich insights. In addition to the work he does at Howard Brown, I don't know that there's a committee, subcommittee, panel that's ever been organized in this state that hasn't at least picked David's brain or invited David to participate. So I want to thank the 3 of them for jumping in this morning. I'll ask you guys to turn on your cameras so I can start to turn the talking stick to you. Just on the housekeeping front, for those interested in that. We will go through some comments and some discussion. I would invite you to use the Q&A button or the chat panel to lob any questions in this way. Myself and Megan will be monitoring. We'll focus a little more heavily on questions in the last from all of you in the last few minutes of the discussion. And anybody that's ever seen me do this knows we will end on time. So you can take that to the bank, and I'll warn my panelist colleagues in advance that even if we're mid-sentence, we will end on time. But I'll make sure I don't put you in a bad position for that. So Jordan, I want to kick it back to you, and then I want to go to Leader Hunter, and then finish with David. I shared a few things. You don't have to respond to those directly, but would just love you to spend a couple minutes sharing any of the insights or thoughts you've had about the last year and a half, and maybe even more so kind of what you're anticipating, watching out for, hoping will happen in 2022.
Thank you, David, and really appreciate your comments and agree with a lot of what you had to say. And as everyone knows, 2021 was another challenging year for the healthcare industry and hospitals. But I do want to begin by focusing on some of the positives. Mainly there was an increased focus on health equity and addressing healthcare disparities. And David, you're absolutely right. We can no longer just talk a good game. We need to see action. I think there was a number of significant actions taken last year. One of those is, involving Leader Hunter and Representative Camille Lilly leading the charge on passing one of the most comprehensive, if not the most comprehensive, health equity reform laws in the country. So now we have healthcare providers that are required to take implicit bias training, and community health workers who we know are critical to care coordination that will now be reimbursed by the Medicaid program. And that law also provided, much needed additional financial assistance to our safety net hospitals through increased psychiatric rates and a $50 million pool of funding to preserve and enhance OB services. We also saw the Illinois General Assembly pass and the governor signed legislation codifying telehealth coverage and payment parity with in-person services for state-regulated individual and group commercial health insurance policies. And as we enter 2022 and beyond, we need to ensure telehealth coverage and payment parity with in-person services continues for the Medicaid population. David, you mentioned the launch of Illinois' Healthcare Transformation Program. This program really encourages providers to partner together to develop innovative solutions for meeting healthcare needs in their communities. And that's been a vital program to addressing social determinants of health, and it will be continuing into 2022 and beyond. Internally at IHA, we work closely with Rush and University of Chicago Medicine, as well as many of our member hospitals, to create what's called the Racial Equity in Healthcare Progress Report, which serves as a long-term accountability tool to document progress toward achieving racial health equity. And that's something we're really proud of and taking action on behalf of our members and our hospitals. At IHA, we also welcomed our new Assistant Vice President of Health Equity and Policy, Lisa Weichman-Harries, out of Rush. This is our first leadership position, 100% dedicated full-time to advancing health equity. So we're very happy to have Lisa join us. So those are just some of the positives I wanted to highlight, David. And while there's a lot to celebrate in 2021, there's no question that the COVID-19 pandemic has continued to place a significant strain on hospitals and all of the healthcare heroes who have been on the front lines caring for their communities. Frankly, our members and their staff are experiencing organizational fatigue across all departments, whether it's food service, security, housekeeping, clinical, or administration. COVID also continues to exert serious financial pressures as hospitals face increased costs due to the shortage of nurses and other staff. So in 21 and continuing into 2022, I'd say the nurse staffing shortage represents one of the most urgent challenges facing Illinois hospitals and health systems, which are incurring higher costs to recruit and retain healthcare workers and really paying unsustainable rates charged by some nurse staffing agencies. And that's why we've seen state legislation already introduced to regulate nurse staffing agencies. And on the federal level earlier this week, nearly 200 members of Congress sent a bipartisan letter to the White House urging federal agencies to investigate nurse staffing agencies. So this is a serious and significant issue that must be addressed in 2022. And I would anticipate IHA and a number of other healthcare organizations to push hard for a solution.
Thank you. One of the things I always so appreciate about anytime I interact with you is your incredible sense of optimism, because it can sometimes help to even balance out my the sometimes jaded or cynical view of the world. And I think you're so right. I won't pick on a time frame or any specific names or individuals, but I can imagine Illinois political leaders or market leaders of years past, had they faced kind of the current set of circumstances, we would not have been served nearly as well. And the truth is, there are some incredible leaders right now we have in the city and in the state, and they certainly do deserve a lot of gratitude as we collectively try to move even further faster. Leader Hunter is one of those. I'm not blowing smoke. I am constantly impressed with Leader Hunter. And so, Mattie, why don't I turn it to you for a minute to share some of your general observations before going to David.
Good morning, David, and thank you for inviting me to be here with you today. I'm really happy to be here, actually. I've been passionate about actually fixing the healthcare system for most of my adult life, okay? And I think that the COVID pandemic really showed us all the flaws that our system and further exacerbated disparities that already existed between the race and class regarding healthcare access and affordability. I was happy to sponsor, along with State Representative Camille Lilly, and support legislation that sought to rectify some of these existing inequities, with my most notable, as Jordan indicated, legislation, that the measure actually being called House Bill 158, and or better known as the Healthcare and Human Services Pillar of the Legislative Black Caucus here agenda to eradicate racism in the state of Illinois. This legislation aimed to remedy the fraction of this broken healthcare system, and it addresses the following areas in this package. Access to healthcare. You guys been talking about this already. Hospital closures, and we included the hospital closures because of what was going on with Mercy Hospital, and we couldn't believe that in the middle of a pandemic that the owners would decide that they were going to close the darn hospital. And we as legislators, as well as the community, got together and said, we don't think so, And so we protest and we marched until we were able to keep it clean, keep it open. And we're working now trying to build it back up. And so also managed care organization reform. There's so many gaps and just too many gaps in services. We included in their community health worker certification. We wanted to put healthcare workers back out in the streets, going door to door, to find out what's really going on with our people out here in the streets. What do you need? Do you need, can we connect you up with some affordable housing? Do you need follow-up? Are you actually getting the services that you need or that you think you need? And what do you need? What can we do to help you? So that you can remain healthy and stop running into the emergency rooms whenever you have an emergency. Learn how to better take care of yourself. That included also maternal and infant mortality, mental and substance abuse treatment, hospital reform, and including medical implicit bias. So many doctors are biased towards their patients. And so we just so many problems that existed and over the years, and this was like a culmination of the 20 years that I've served in the legislature, that I've seen many of these issues, if not all of these issues, be presented to us. And so I want to thank all of the community providers that came together and helped us pass this legislation. They testified at the hearings, they provided research, they just had expert witness testimony to back up and to verify exactly the categories that I just mentioned, and without them, this Black Caucus legislative pillar would not have been possible. And so with the implementation of this bill and a few others that were passed last year, such as the expansion of telehealth and the hospital transformation bill, I am really, really confident that the state's healthcare system is progressing and will progress and will continue to work on the measures that further improve the quality, accessibility, and the affordability of healthcare for all of us in here in the state of Illinois. So thank you very much.
Thanks, Leader Hunter.
Thank you.
So many things in there I'm eager to pull on here in a few minutes. But again, really do appreciate your what I know have been exhausting and exhaustive efforts to move so much of this policy through. David, life on the ground, in a clinic, in the trenches, what are your thoughts?
Thank you, David. Great to be here. Thank you, Leader Hunter, for those great remarks. And Jordan, thank you for the warm introduction and for hosting this. I too am optimistic for 2022, but I do want to say that 2021 was really difficult for Howard Brown Health and our 11 clinics from Rogers Park to Inglewood and most community health centers. And the ambulatory care system has just gone through a tremendous amount of change, and and I feel like the sector is destabilized because of 2021. And I never thought I would say that things could be worse than 2020. 2020 was so difficult, going into a lockdown and kind of changing. Our whole world changed, and the whole world changed at the same time. But 2021 was really stressful. And, we started the year by continuing our testing efforts that we were focusing on the South and West side. We immediately ramped up vaccination campaigns when they became available in January, and spent most of that early part of the year rationing vaccines and trying to get them to those who were indicated based on the phases of need. And by May, the whole world thought that the pandemic was over, and and we were coming out of it. And then Delta hit us in July, along with the Great Resignation dynamics, and we saw enormous numbers of patients return to inpatient care in August to October, which was fantastic in some regards because there were individuals who had foregone care in most of 2020 and needed care. And telehealth, though we ramped it up, has limitations. Certainly some of the labs and in-person evaluation cannot be completed, and that hit us like a tsunami. I mean, there was more demand for in-person services than we had capacity, because it just happened so quickly, and at a time where there were so much changes in the labor market. So we had a lot of people, like we've been reading, reevaluating their career, going back to school, changing jobs, moving out of state. And so that was very unstabilizing. And then, end of the year, the Omicron spike hit us at the worst time. I mean, we had so many people that were out on planned paid time off for the holidays. And at the end of the year, we had 10% of the workforce had documented Omicron. And so we were trying to maintain our services at a time when we were really struggling with sufficient staffing. And our workforce had many of the same needs as our patients and community. And we're also scrambling for testing scrambling for answers, recuperating from COVID. So, I think for me, the lesson really is that, we have so much more to do in emergency preparedness. I thought, we would be better positioned after living through 2020 and 2021, but that end of year really showed how very tenuous our plans are to activate and how vulnerable we are to meet demand. And then, the workforce needs that you've identified are very real and substantial. And I think particularly for our non-licensed staff, which are the backbone of our system. So our health educators, our medical assistants, our front desk, and others who, absolutely are on board with the mission of serving the public and meeting their health needs, but do not have medical training and still struggle to understand the risks and the mitigation strategies, and have been tremendously scared. And I've also also been hit hard by inflation. So, our ability to keep up with the market in a time of rising inflation has been really tough. So I think I think we have a hard year ahead, but I am optimistic, even though I don't sound like it. But I do. But I guess I'm also I'm absolutely aware of our vulnerabilities in a way that maybe, after the hope of the vaccine push and seeing conditions in the pandemic subside in May and June, lulled us to believe that we could imagine a world that was pre-COVID, and I don't think that's possible anymore. I think it's here to stay.
Yeah, I so appreciate those remarks, and I will have to express an apology for the irreverent chuckle I gave when you said you couldn't imagine how anything could have been worse than 2020. Completely involuntary, because so well said. I think you're exactly right, and God willing, we won't be saying the same thing about 2022 in comparison to the last couple of years. David, I want to stick with you for just a second as we start to unpack some of your all's summary comments. And Jordan obviously rightly raised workforce and how that's affecting his members, and you obviously just articulated that very well with the on the ground perspective. Can you, David, just talk a little bit about how you and or some of your colleague FQHCs are thinking about this in the short term and in the long term? And, if you had a magic wand, and obviously if you had a magic wand, you would just wish for the problem to go away, but let's pretend the wand doesn't do that. Let's pretend you could wish the MCOs to do something different, or Springfield to do something. Like, what are one or two things in that shorter long-term context that can start to ameliorate some of the pain?
Yeah, no, that I have been thinking about that, and thank you for that question. We're thinking aggressively about how to better support the workforce, but there are so many limitations to our ability to do that. I think certainly for our medical staff who are not licensed, if there were government programs to help train them on just some of the basics of infectious disease, medical protocol, mitigation. I think we take for granted that some of our lay workforce or non-medical or non-licensed workforce can comprehend some of these concepts. And so I think that, we're doing a lot of that. Howard Brown does have several board certified infectious disease physicians. And so we've been relying on them to present on the changes, the data, what we know about the variants. But even that's still just, and that's still been a challenge to connect, to kind of support our staff with what they need to know, not only for work, but for their lives, kind of in the community. And most FQHCs don't have infectious disease professionals as part of their network. So I think workforce development would be a big benefit. Any funding support for emergency preparedness. I still think we're just not we've been just on the hamster wheel and trying to meet the next immediate challenge. And we saw how woefully ill prepared we were with the end of year Omicron spike. Employee health has been another area of enormous need. So, we had at some of our clinics at the end of the year, 2 to 3 hour lines for COVID testing. And so, and I'll say our positivity rate at the end of the year was 33%. So 1 in 3 of our patients who were turning to Howard Brown were testing positive for COVID. Our workforce was competing with our community for our testing resources. And, and we had hundreds of staff who needed COVID testing. And so that was a real strain. And, even though we have third-party contracts for some employee health, they were slammed. And so it became a real obstacle. And that's something that, there could be some partnerships that could help provide some employee health resources for community health workforce, as well as other healthcare workforce. And then lastly, I think we have a walk-in sexual health clinic that does STI, HIV testing, pregnancy testing. That has ballooned into really an urgent care model, and patients who have averted care for most of the pandemic or longer are walking in with very complex health needs and needing insurance navigation, behavioral health, suicide ideation, prevention, substance abuse needs, you name it. And so meeting that demand has been very difficult. And, I guess we're grateful they're not going to the ER because the ERs have been congested with other, life-threatening needs. But meeting that demand has been very difficult just because it's unscheduled. It's also an opportunity we want to seize because these are folks that historically have avoided the system. And now they're in our clinic and they're asking for help. So we want to do everything we can. But given all the dynamics, that's been a difficult lift.
Jordan, same general question, but we had a panel of, let's say, 5 hospital CEOs, in the city or through the state, and we kind of asked them the same workforce question: short term, long term, magic wand, knowing you can't just fix it. What do you think they would be saying?
I appreciate that question, and that's how we're viewing the workforce challenges. What can we address in the short term versus the long term? And David, I appreciate your comment about my optimism, but I think you also know me as someone who can be direct and straight to the point. And I can't emphasize enough the workforce shortage that we're experiencing and how significant of an issue it is, not only for our member hospitals, but for communities and patients that rely on the workforce. And this is nothing new, right? Healthcare leaders have long signaled concern of a growing workforce shortage, particularly around nurses in the hospital setting, and COVID-19 and its numerous surges have only exacerbated this existing issue. And in fact, prior to the Omicron surge, numerous Illinois hospitals and health systems reported to IHA that they lost nearly 15% of their nursing staff. This shortage has really created an immediate financial crisis of traveling agencies charging as much as 4 times more for nurses. And the demand for nurses is so high now that traveling nurses are often no longer required to travel. They're working only minutes away from the hospital that previously employed them, or they're hired back to the same hospital at significantly higher rates. And then, of course, hospitals are increasing the wages of their staff to retain them. I was on a call yesterday with our hospital's chief medical officers, and many are reporting that 30% or more of their staff are from staffing agencies. So, as I said, this is a really significant and serious crisis. So we think in the short term, continued investment in hospitals and in the healthcare industry to curtail the staffing shortage is going to be vital to ensuring access to quality and timely healthcare to all individuals in Illinois. I alluded to this earlier, but the nursing home industry is pushing legislation to regulate nurse staffing agencies. We are currently reviewing that legislation and discussing it with our membership. We've also been in discussions with the governor's office and state legislators and our federal delegation on other potential solutions to address the high costs and practices of nurse staffing agencies. In the short term, we're also pushing for passage of the Nurse Licensure Compact, so Illinois can join a majority of states in allowing licensure for out-of-state nurses. And we've seen during the public health emergency, the Pritzker administration has allowed for temporary licensure for out-of-state clinical staff, and that's proven to be extremely successful. So we'd like to see that codified. Beyond that, longer term, we need to continue to address the overall nursing shortage through home growing the nursing pipeline. This isn't an Illinois problem. This is a nationwide problem. We've seen other states like Kentucky and California and New York announce significant investments in the healthcare workforce of their states, and we're going to be encouraging the governor's office and elected officials to do the same. We're also hearing that, we have plenty of nursing students and candidates, but we don't have enough faculty to instruct them and to teach them. So we need to grow the faculty in nursing programs as well. Beyond that, and we're focusing on one challenge with the staffing shortage, but other priorities for the Hospitals Association and for hospital members this year is reauthorization of the hospital assessment program. This program generates $4 billion annually in hospital Medicaid funding. It's also a top priority this year. And this funding is also critical to preserving and enhancing access to quality healthcare for the 3.8 million people who are insured by Medicaid. So a lot of financing opportunities that we'll be pursuing and advocating for in the short term, and in the long term, really continuing to focus on growing the workforce pipeline, so that we get the adequate amount of resources and workforce that we need to serve the patients and the higher demand that we're seeing for healthcare services now, and will likely continue to see in the future. As David noted, we've had a number of people that have deferred care, whether they've been afraid of COVID and unwilling to seek care. We've had our hospitals that have had to pivot throughout the surges and have had to do surgeries, and that's had an impact on people's health, and that's going to be felt, and it's going to be with us for a long period of time.
Jordan, thank you. Leader Hunter, I want to go back to you and start with the same base question, but I'd like to extend it or expand it just a little bit. So any of your thoughts or reactions on the workforce crisis challenges? What are things you're thinking about from a policy-making perspective? And then Leader Hunter, if you'd be amenable to just, after commenting on workforce, maybe just kind of pivot a bit into how did you wake up on January 1st and think about 2022? What are the things that feel really important to you? What are the things you're hoping to see from stakeholders in the community, from the governor? Any of those things that you're either flowing from the work that's been done over the last couple of years, or different areas where you're enthusiastic about pushing something forward. Oh, and you are muted, my friend.
Sorry about that. Thank you. Yeah, thank you for that question. And I hear very clearly what David and Jordan has articulated very clearly to us. We know that there's a shortage of work. There's a workforce shortage. There's been a shortage of nurses for a very, very long time. And I don't think that we have, we've been putting a Band-Aid on trying to fix that issue and not really addressing the real issue. But I do know that we have been meeting quite regularly trying to address some of these issues. But I know that for a fact, I'm working on a bill to create this healthcare workforce repayment plan, and the healthcare and this healthcare workforce scholarship program to encourage healthcare providers to relocate and practice in certain areas of greatest need to increase the diversity and community representation of our state's healthcare workforce, and to better meet the needs of the underrepresented communities. And right now, that's Senate Bill 3734. And my colleagues have other pieces of legislation where we're working on trying to put more dollars by changing the rate in safety net programs and hospitals. There's a lot that has to be done. We're working on it. We're focusing on it. Which we're last year, we passed Senate Bill 2294 to overhaul the Medicaid, and I think that we can probably get some relief once we can get our Health and Human Services pillar implemented. The implementation is going to be very important. Which one will focus on communities and workplace and inequities. There's so many different task force advisory committees and commissions that built into that implementation period. And we're working with the department, I believe we've identified people to sit on these committees and different entities so that we can get their input. And there's just a lot of things, a lot of different moving balls that are occurring right now down in Springfield. We have not spent all of the federal ARPA dollars. And so we're looking to figure out how to spend those dollars where the greatest needs are. And so we have this issues implementation group where we're looking at a number of issues, workforce, unemployment, education, economic development, And so once we can finalize those pieces, we'll be able to roll it out. But before we roll it out, of course, we'll have to run it past the industry, hold a few hearings. Most of the folks like Jordan and David, they find out what we're doing before we do sometimes. And that pipeline is very strong and heavy, and sometimes folks like Jordan and his folks, they'll call me and say, hey, I hear you all are working on this and that and that and that, And I said, now, how did they find out about that?
It's kind of impressive, right? It's like some omniscience.
Yeah,
you're good at your job.
Absolutely. And so there's a number of moving pieces that we're working on, and our legislative session is going to be short this year, where we're scheduled to adjourn the first week in April. And so we have a lot of work to do within that very short period of time. And so that's why we're meeting like different kind of meetings and hearings that are going on like 10, 12 hours a day, because like I said, and plus, so anyway, the fact of the matter is that we hear you, we are aware of many of the flaws and gaps in services, and our eyes are wide open and so are our ears, and we're listening so that we can put the needed resources where the greatest needs are.
Leader Hunter, one other thing I wanted to ask you about, I think all of you in your summary comments at the top of the panel shared or reflected a little bit around behavioral health and some of what we've seen there. Obviously, maybe not obvious to everyone, but you started your career, I believe, in behavioral health. And so I know it's an area and just knowing you and hearing you speak, I know this is an area of high importance. And if behavioral health was kind of an urgent issue in 2019, it's sure as hell an existential issue as we come out of this and as we all heal, find a new normal, whatever the case may be. Anything, obviously, a lot of the Medicaid work that was done last year should hopefully owe to strengthening behavioral health linkages, but anything else you're thinking about in 2022 or in the context of COVID that you'd really like to see happen with behavioral health in the state?
Yeah, thanks for that question. It's really a good question. There's a workforce shortage also in the behavioral health field. Huge workforce shortage, you know.
Like debilitating.
Yeah, and so we're looking at restructuring that field and putting some more resources, trying to encourage more people to get into that particular behavioral health field. Look at the mental health situation. You know, over the years, we've defunded on a national and on a local level mental health services and dollars. And because of COVID, it has truly exploded to the fact where all kinds of folks that we never even thought of are presenting with mental health issues. And so, so we have folks, an increase in mental health need, as well as a shortage in workforce in the behavioral health field. And so the governor does have, under the Department of Human Services, this R3 is a restore, reinvest, and renew. And these are areas that'll help us prioritize where the state dollars should go, and focus a whole lot on a lot of trauma training and looking at licenses and a number of other things that we're looking at. I've been in behavioral health since 82, actually, 1982. And I'm certified. I'm a certified alcohol and drug counselor, treatment, prevention. I've run programs. I've run inpatient, outpatient programs, ran programs over at Cook County Jail, you know, and I really do know firsthand what's going on out there. But, you know, we got to put more resources out there, and not only resources, but we just have to identify and encourage more people to start majoring in the behavioral health field, working with our universities to provide the training that these folks really, really need, so that you know, they can help relieve the pressure that are existing right now in the behavioral health field. So we're working on it as well, guys.
Thanks, Leader Hunter. For those keeping track of time, we have about 7 minutes remaining. So if there are questions from those of you who are online and watching, please feel free to submit those. One question that came in, and Jordan, I'm going to pitch this in your direction. You know, are there specific or direct consequences from or that we might experience from the continuation of COVID-19 this year? All right, so epidemiologists, public health officials kind of expect this Omicron wave to taper over the next 30 to 60 days. That's great. That doesn't mean it's eradicated.
Yeah.
What happens if there is another variant that's more resistant to the vaccine or the like? What are some of the things that you and your members will be thinking about, and how should the state respond? And by the way, you've got like 60 seconds to answer that. So my best wishes to you.
Thanks for that question. I think that's a great question. And, you know, I want to go back to something that David said earlier about being on this constant hamster wheel. And I think we're going to continue to be on that constant hamster wheel with really no time to think other than addressing the issues that are right in front of us. But I will say the one thing is that we're all on this hamster wheel together. And I think if there's any silver lining, going back to me being an optimist out of this pandemic, is that all the stakeholders are at the table. And I think I see greater coordination that I've seen in the past. So it's not just hospitals, you know, in one bucket. It's not just FQHCs and mental health providers. We're really all talking together and coordinating and working with social service agencies and nonprofit organizations to, figure this out together and to address the needs of patients and communities, especially those that have been hardest hit by the pandemic. So I think that's what we're continuing to focus on, are these strong relationships and partnerships that we've been able to build. We're breaking down the walls and breaking down the silos, which makes for better, care coordination and coordination of services, which, provides, better access and quality care. So I think that's what we're going to continue to focus on now and into the future.
Thanks, Jordan. Question came in. I love this question so much. So from Jamie Orlikoff. Jamie, I don't know that we've met, but I really do love your question. She says, provocative question, the press continually refers to quote, hospitals on the brink, or quote, hospitals at the breaking point. So how close are we to system collapse? David, I'm going to pitch that to you first. I know you're not a hospital system, but you also used some language in your comments that the sector is now destabilized. That really punched me hard. How close are our community health centers, community mental health centers to quote unquote collapse? And then Jordan, if you could feel that too. And again, guys, we're down to like 4 minutes, so you got to do super pithy answers for me if you can.
Sure, thank you. Yeah, I mean, the backbone of the ambulatory, community health network are lay staff workers. Even though we rely heavily on providers, medical providers, and mental health clinicians, but it's the medical assistants, the health educators, the facilities workers, the front desk, the call center that support access to care for patients. And I think that workforce, the market rates are very low. They've been hit hard by inflation, and I think we are vulnerable because that category of workforce is scared, and they see this work is very difficult and traumatizing, and we're seeing a lot of turnover in that area, and that's what makes me concerned. And I think there's a lot more we can and must do to support that workforce. It's also an entry point for careers in health. So for individuals with an associate's degree and a high school diploma can get into healthcare work, healthcare careers through a medical assistance. I would love to see us start, efforts regionally or at a municipal level to plan for the next variant. We are fooled to think that this is it. And I think we should start some emergency preparedness and think about how we can support each other, because all of us are dealing with the same kinds of issues, but on our own.
Yeah, so well said. Jordan, same question. How close are we to quote unquote collapse in 30 seconds or so?
Yeah, Jamie, thanks for that difficult question. And it is very provocative. I don't think we're close to any system collapse. I think what I've really been impressed with is our hospitals' ability to become innovative and to manage their resources in the best manner possible. I will say, staffing shortage, significantly low Medicaid rates paid to hospitals that rely on government payers. These are things that we've been warning about for years and decades. So, without immediate government assistance, I think we could get to a point where, you're seeing, perhaps, providers shutting down, decreased access. We need a workforce to actually take care of the individuals and patients within the community. So I don't think we're near, collapse, but we need immediate and long-term assistance to ensure that we don't get close to that point.
Jordan, thank you. And thanks for, apologize for forcing the brevity. Normally I'd close this out with just kind of a lightning round, but we won't have time for that. But Leader Hunter, I wanted to just kind of throw one final direct question in your direction in our last minute or so here. And that's how are you generally, not a less fluffy way to ask this, how are you feeling? Are you optimistic? Are you trepidatious? Are you pessimistic? As you think about the legislative session, everything that has been done, everything you're working on, are you excited about where we're going? and how much more of our backs, our collective backs, do we need to put in the market and in policy to continue to move us in the right direction?
Yeah, thank you for that question, David. I'm very optimistic. I don't believe that we are going to have any kind of collapse or anything like that. Our system is being challenged. That's the way I see it. Okay. And I know that there are shortages. I know that there's a number of things that are going on, but just know that we're working on things. We have a very, very strong community provider system here in the state of Illinois. I talk to my colleagues all over the country, and they don't have the kind of education, they don't have the educational systems that we have here in Illinois, as well as the provider and the collaboration and the partnerships that we've developed over the years. And they're very, very strong. You know, we've always had an open door policy where the providers can come and sit down with us to tell us what their needs are, and we try to figure it out. You know, and so I'm hoping that with the medical system and the educational system that exists here in the state of Illinois, that we all can come together to figure it out. Our educational systems, the educational systems of the universities, the private and the public university system, they have all kinds of training programs going on. They have all kinds of internships programs going on. And I'm almost sure that we just need to speak and talk to them a little bit more, as well as work with the hospital system, whether it's a FQAC, whether it's a safety net, whether it's a public and private hospitals. It doesn't matter to me. We got the systems, we got the collaboration. So, hey, we just need to sit down at the table and figure this thing out. There's nothing that we cannot challenge and we cannot complete. There are all kinds of challenges out there, and I am very, very strongly optimistic that we can solve our own problems and we can get it done quickly.
Woo! Preach, Leader Hunter. But a great way to close us out. Thank you for that. Thank you for the optimism. Hey, listen, I want to thank all three of you guys for the time this morning. Really engaging, enriching discussion. I want to thank those of you that have dialed in or tuned in, so to speak. Thank you for your time. Another special thank you to the Illinois Health and Hospital Association for supporting the event, supporting the paper, their continued partnership. We all have a lot of work to do in the weeks and months ahead, and I share that optimism. We are moving in the right direction. We know a heck of a lot more about the system, its mechanics and its functions and dysfunctions than we did 2-3 years ago. And there has never been a moment like the present moment to organize everything we know, put it together, and create a better system that serves our city and state better. So thanks to everybody. Have a wonderful, it's Wednesday. Have a wonderful Wednesday, and we'll see you all next time. Thank you.
Thank you.